When you're in so much pain, you feel like you're dying and nothing is making it better, you need help. Where do you go when you're in pain and you need help? An urgent care or an ER. But what happens when the ER doctors don't believe you? Why, when we're in severe pain and we go to the place we're told will help us, do we so often get told we can't find anything wrong? Why do we get vastly different treatment from one emergency visit to another? Why can't people with severe dysmenorrhea rely on these places for help?
What's happening to your body, we don't know, because we've never really studied the female body. Say it's all in my head, but the research is quite spotty. No, we've never really studied the female body. I go to the doctor to get dismissed. Try losing weight, you're just anxious. That's fine, that's cool, I'm not pissed. Just wait 10 years for a diagnosis. Psychosomatic, you're so dramatic. Hysterical, emotional, hormonal, erratic. Heart disease, chronic fatigue, depression and anxiety. Do you have pain? No, you don't, because we've never really studied the female body.
Welcome back to Cramped. In our first episode, we got some answers to questions like, what are cramps? And why do cramps hurt? What conditions might cause severe dysmenorrhea? If you haven't listened to that one yet, maybe go do that, and I'll meet you back here. Today, we're talking about what happens when your period pain is so intense and debilitating that you need medical intervention like right now, and the many reasons it can be so difficult to get the pain relief you desperately need. And since going to the ER is never fun, I brought a friend.
Hi, my name is Sydney Battle, and I have a uterus.
Congratulations.
Thank you. I'm Kate's friend. I'm an actor and a writer and a podcast host.
And then when did we first start talking about our periods with each other?
I feel like it must have been fairly early on because I didn't stop having severe pain until like a few years ago.
Yeah.
And so I was probably going through it. And then we were like, oh, wait, sister.
So you no longer get period pain?
Not really. I do, but
Oh.
it's like the normal kind that I assume other people who have a uterus get.
Right.
If they are lucky enough to have a normal period.
Regular cramps.
Yeah. The pain I have now is manageable with ibuprofen or Tylenol. Occasionally I'll have to use something a little stronger, but it's pretty wild to be able to function normally and not be such a little weirdo about my pills.
I'm going to ask you to tell the story of how you got to a place of no pain after we talk about being in pain. So,
Okay.
when your cramps were really, really bad, can you talk about what kind of pain that was, what that felt like?
I think they started to get really bad when I was around 14 or 15 because I first got my period when I was 11 and a half.
Oh, wow.
I remember that I was wearing footy pajamas.
Oh, no.
And I thought it was like crazy that I was being ushered into womanhood in children's pajamas. Like that was so poetic in a way. The intense pain didn't start until a few years after that. I remember my mom being, I think, out of town for work, and I was just collapsed in pain on my bathroom floor. I couldn't stop throwing up my own stomach bile,
Yeah.
which means I was throwing up bright yellow. It looked like Mountain Dew.
Ew.
And I was like pale and shaking. And my dad was really freaked out to the point where he put me and my sister in the car and started driving me to the ER. But we did have to stop in the driveway so I could open the door and throw up on the ground. And then we kept moving. I got to the hospital. They had to put me in a wheelchair, but they were all out of wheelchairs. So it was a wheelchair for people who are about to go through weight loss surgery. So I looked so tiny because I was a 15-year-old girl in this giant wheelchair. And they wheeled me in. They put me on a morphine drip.
Yeah.
And that was effective.
Right. Morphine sure will take it out of you.
Yeah, it's pretty great for that. And then they took me to get an ultrasound and they were like, you don't have endometriosis. And I was like, okay, cool. Go back to my bed, still on the morphine drip. My mom shows up And she was really angry that my dad had brought me to the hospital.
Oh, really?
Yeah, because in her mind, she was like, there's no way that she's experiencing a pain that justifies this.
Oh.
And I think it's probably because, you know, our moms have had periods themselves. They're like, she could have rubbed some dirt on it and she would have been fine. You got suckered by this 15-year-old girl. And meanwhile, my dad's like, no, I think this is really serious. They have her on a morphine drip.
Yeah.
And that day I got a Vicodin prescription.
Wow, for a 15-year-old.
Yeah. They're lucky I was responsible.
Yeah.
Yeah.
Wow.
But at that point, I think I had tried muscle relaxers. Like my family doctor had given me muscle relaxers and they didn't work. In fact, that day I had taken a muscle relaxer and I just threw it up.
Yeah.
And nothing could stop the pain.
Oof. I hate getting to that point where you're like, oh no, I waited too long to take the heavy duty meds. And now nothing will stay down and I just have to weather this storm.
The pill window. I used to call it my pill window. And the second time I got taken to the ER, something I kept saying in the ambulance was, I miss my pill window. Yeah, it was after that second ER visit. So I must have been around 25. I got diagnosed with stomach ulcers.
Right.
And the doctor I went to, when he asked me about like what kind of pills I was using and how I was using them, and I told him, he was like, your stomach lining should have given out years ago.
Yeah.
It's actually incredible that it took you this long to have ulcers because, you know, I've had this for most of my life. And so I was in college binge drinking, taking 600 milligrams of ibuprofen and a strong pill.
Yeah.
I mean, I still have medication that I have to take when my ulcers flare up.
Oh, God.
Yes. I wish someone could have done something more to help me than just giving me a bunch of pain medication, obviously. And they're really lucky that I didn't become addicted to any of it.
I mean, I don't know. It's not that they're lucky. It's that
I'm lucky.
You're lucky.
Yeah, they don't give a shit. But I'm also like, what could they have done?
This is why I love hearing other people's ER cramp stories. Every person's experience is unique. Some positive, lots of negative. But look, going to the ER for period pain never gets you the same treatment twice. Case in point, I have two very different ER stories. So the first time I had to go to the ER for period pain was when I was living in New York. I was living with my grandparents in Manhattan, and they were away. So I was alone in the house, and I was having death cramps. I was throwing up every 10 minutes, throwing up Mountain Dew colored bile. And every other time this had happened to me in my whole life, it had just gone on for like 3 or 4 hours, and then I had passed out. And then when I woke up, I was fine. And so I was like, okay, I can just deal with this for 3 or 4 hours and then I'll pass out and then I'll be fine.
Yeah.
But I never passed out.
Oh.
I just kept throwing up and having diarrhea for 6, 7 hours.
Jesus Christ.
Like a whole day went by and I was like, what is happening? Like, and by that time, you know, you're completely dehydrated. You can't keep anything down.
Yeah.
It's exhausting. All the muscles in your body are just wrung out. And I was just like, I don't think this is ever going to stop. I have to do something because I can't
die.
Like, I'm going to die if I can't stop throwing up. And so I was like, I guess I just have to go to a doctor or an urgent care. And I knew I couldn't afford to call an ambulance. But because this was Manhattan, there was an urgent care around the corner from my grandparents' place. And I like stumbled to the front of their building, got a cab, took the cab like, I think half a block and was like $3 bills at the guy. And then went into the urgent care and was gray, drenched in sweat, hunched over, huddling, waddling.
The position.
Yup.
I know exactly what you're talking about.
Yup. I checked in at the front desk and I was like, I have dysmenorrhea. I have cramps. I can't stop throwing up. I've been throwing up for 6 or 7 hours. I just need something to stop it. And they were like, okay. I don't remember waiting very long at all. And they put me in an empty room. They gave me an IV drip with saline and a muscle relaxer in the IV. And then they turned out the lights and they were like, we're just going to let you sit here for like 20 minutes. And they just let me sit in this dark room by myself with the IV. And it was quiet and it was peaceful. I could feel the IV in my veins. Within 5 minutes, I was 100% fine.
Wow.
It was so crazy how fast it worked. When they came in to get me, I was crying. It felt like, oh my God,
Yeah.
I found the cure. And I think I walked back to my grandparents' apartment from there because I was just like, I feel fine.
Yeah.
It was incredible.
Once it passes, it's kind of crazy how you just snap back in.
Yeah. Not only do you not feel bad anymore, you feel so good.
Euphoric.
Yeah, euphoria of, oh, the pain is gone. Like, why don't I appreciate not being in pain all the time? So that's my first ER story, or urgent care, technically. It's surprisingly straightforward. Really quick and effective treatment. Basically exactly what you want when you're in horrible pain and you need help. I've looked into why the IV muscle relaxant and saline was so effective, and it seems pretty straightforward. The uterus is a muscular organ, and like we learned in episode 1, the pain of cramping comes, at least in part, from the muscle squeezing so tightly that oxygenated blood can't flow to the muscle. A muscle relaxer relaxes that muscle and lets the blood flow normally. And since I couldn't keep anything down long enough for it to get into my system, the IV bypassed my stomach and got it directly into my bloodstream where it could go to work immediately. And the saline just gave me some hydration. Although I've also read that dehydration can make any muscle cramps worse, too. What I don't know is why this isn't the first thing they try anytime someone has horrible cramps. Or why there isn't a service for this like they have for like hangover IVs. I don't think I'd be able to afford it, but man, would it be amazing to be able to call a hotline anytime, day or night, and have someone show up at my house with an IV bag full of muscle relaxant and saline anytime I'm having death cramps. Or regular cramps. That's the world I want to live in. Unfortunately, we live in a world where the next time I had never-ending death cramps, I got a very different treatment. It happens years later. I'm living in Brooklyn with my boyfriend at the time, now husband, Matt. You know, I missed my pill window. I was throwing up, and I was like, okay, this will be a few hours, and then I'll pass out. But I never passed out, and it just kept happening. And after 6 or 7 hours, also Matt was like very worried and was like, what do we do? But what do we do?
It kind of looks like The Exorcist, I'm sure.
Yeah.
Every exorcism in the past was just a woman experiencing dysmenorrhea. And they were like, oh, God, Satan lives.
Yeah. We lived just a few blocks from a hospital, and he put me in a cab, and we went to the hospital, to the ER, and waited in the waiting room for, I want to say like an hour and a half.
Oh my God.
And they like gave me a plastic bowl to throw up in. I was like, this is dysmenorrhea. This happens to me every once in a while. This is really bad though. And last time they gave me an IV muscle relaxer and saline, and it immediately cleared it up, like no problem.
Mm-hmm.
And they were like, okay. And they wrote it on my chart. And then I finally got a bed and waited forever for the doctor to come by. And I told him, okay, this is severe dysmenorrhea. I'm still throwing up every 10 minutes. But last time this happened, and I went to an urgent care, they gave me an IV, muscle relaxer, and saline. And like, if you just do that, it will go away and I can leave.
Yes.
And the doctor hears me say this and says, oh, did you eat anything that had been like sitting out for a while? Sir. I was like, first of all, I've thrown up everything that's ever been inside my body.
Do you not see the bile? There's no food in there. There's nothing else.
No, this isn't food poisoning. This is cramps. I just got my period. This has happened before. It's not food poisoning. And he goes, okay, we're going to put you on an IV anti-nausea and see if that clears it up. So they put me on an IV anti-nausea and then left me there for an hour. And I was having to like roll the IV thing to the bathroom every 10 minutes to throw up or have diarrhea. And
yeah,
I was crying. I was just like, I'm in the hospital. Like, they won't just give me muscle relaxants.
I think they truly cannot conceptualize the idea of being in so much pain that you're throwing up.
Yeah.
It's not that you're nauseous. It's that the pain is so intense, your body is rejecting itself.
Yeah. It's doing anything it can think of to fix the problem.
Yeah.
And so after like an hour, they come back. I'm still throwing up. I'm like so close to passing out. I'm in so much pain. And they're like, okay, I guess it's not a nausea thing. Okay, we'll give you an IV morphine.
Oh, well, I won't complain about that.
Right. So they give me the morphine, but I immediately pass out from the morphine because my body is so exhausted. And I'm passed out in the hospital bed for at least an hour. And finally, I like come to, and then we get checked out. And a couple weeks later, I get a bill for $18,000 because that hospital was not in my insurance network.
Kate,
and
what?
Wait, I had to go down such a dark road of begging them to lower the bill. I think they ended up lowering it to $10,000 and I just paid it over the course of years.
What?
I carried that medical debt for years. Yeah, to not get helped.
Oh my God.
Yep.
Jesus Christ.
So those are my ER stories.
Kate, that's insane. $10,000 for cramps.
Yep.
Now I'm like, okay, my mom might have made a point.
Right.
Do I think I should have been at the hospital? Yes. But now I'm understanding why she's like, you let this girl swindle you.
Right. When you put a price tag of $10,000 on it, it's like, what's the worst thing that could happen if you didn't go to the hospital?
Yeah. We could have just hit you in the head or something.
Yeah.
Have you pass out until it
just
passes.
give me a concussion. Yeah.
Yeah. Knock you out until it's over.
So I know after, especially that second experience, I had a lot of questions for an ER doctor of how did this happen to me? Why? How can I avoid this happening to me ever again? Do you find that you have any questions for ER doctors?
I would want to know if there's anything I could do or what's something I can say as soon as I get to the ER to know that they'll take me seriously.
Yeah.
And to fix this with the least amount of money.
Yeah. Okay, those are great questions. We're going to take a quick break, and when we come back, we're going to take our questions to an actual ER doctor and see if we can get some answers.
Cause we never really studied the female body.
Welcome back to CRAMPED. Sydney and I have both tried to get help for our severe period pain at ERs or urgent cares. And we've had varying degrees of success. And I want to ask an actual ER doctor some questions about our experiences. Maybe there's a reason it's so hard to get straight answers and consistent care for period pain. So I called up my friend.
My name is Dr. Darien Sutton. I'm a board-certified emergency medicine physician. I also happen to be a correspondent on national television, and I'm sitting here, my favorite part of the day, talking to my friend. How are you?
I'm good. So you're an ER doctor. If somebody comes into the ER, you're on duty, they are presenting with severe abdominal pain, they've been throwing up for hours, and they tell you, hey, this is dysmenorrhea, this happens to me sometimes. What do you then do? What's the process?
When someone comes in, if they tell me something as straightforward as that, hey, this is my problem, it happens all the time, I'm honestly, I'm not trying to reinvent the wheel, okay? I'm going to go ahead and believe you. And then I don't want to call myself a pushover, but I'm very much an easygoing kind of person in the emergency room. And so I'm not trying to play Dr. House. If you really believe that this is something you've gone through, I'm going to trust your opinion on your body. I don't live in it. But when patients come in and they'll say, I normally have dysmenorrhea and this is a pain level above that, that's what kind of triggers my spidey sense and makes me want to say, what else could this be?
What are the scary things that you want to check and make sure are not happening before you get into the treatment for what is happening?
First, it starts with getting the history, right? You want to make sure that you understand not only their personal history, their story about their pain, but also their surgical history, maybe even family history. It really is important in helping you guide the next part of the conversation. Then you're going to do an exam. And during that exam, you're trying to evaluate exactly where this pain is coming from. Let's say that it's in the right lower quadrant of your abdomen. What I'm thinking as a physician is, could this be really bad dysmenorrhea, what they've had before? That's common things being common. Could this be a twisted ovary? And that is why that history is really important, because maybe some patients will say, I have a condition where I have more cysts on my ovary than the average person. That increases the risk of it twisting on itself, which then can lead to it cutting off its own blood supply and tremendous pain and a diagnosis of ovarian torsion. And then we're still in the right lower quadrant. So could this be not even associated to their genital urinary system? Could this be intestinal, like their appendix? And then thinking about their other parts, like a kidney stone. And then what tests can I do to rule out the scariest things while we're, of course, treating the patient's pain?
Why would someone get bad doctoring in an ER?
I think a lot of not getting good treatment lands in poor communication. I think they teach you a lot in medical school about the science, the biology, the pathology, but I do not remember to this day a class on how to talk to people. So I think a lot of the reason why the feelings of bad service happen is because there isn't good communication, not only in the simple introduction, the hello, my name is, but also in the plan for the day. I think a lot of the way to appease people and calm everyone down in the emergency room is to be realistic about outcomes. Number one, hey, I'm going to try to control your pain. I cannot promise you I'm going to take it away fully, but I want to get it to a point where we can at least manage it and tolerate it and then move on from there. And then, hey, I'm going to do these tests. I may not be able to figure out exactly what's going on, but what I'm trying to do is to rule out the scariest causes of what could be your problem. And then, hey, I'm probably not going to get to the bottom of this, but this is what's important about the follow-up so that we can prevent you coming back to the ER.
Yeah, really someone's going to you for help with their acute pain, help with what is happening to them right now.
Yeah. And they always teach you in emergency medicine where you're trying to figure out whose life is in danger. But to someone who may not realize that, it can easily look like you're not paying attention, or you are avoiding topics that they want to talk about when you're trying to get to another subject. So a lot of this is in active listening and being a good active listener, and then great communication about what is about to happen so that people aren't left in the dark.
Yeah, it does seem crazy that there isn't more focus on that in medical education since, a big part of the job is communicating with your patient.
It's pretty much 90% of the job.
I told Darien the same ER story I just told you and Sydney earlier. Getting the anti-nausea, then the morphine, you remember. So many things about that experience frustrated me, but the fact that there was such a simple solution, why would a doctor hear that and then be like, no, we're not going to do that?
And listen, I'm not trying to be too simple about this, but if you came to me and you explained to me that you have dealt with this problem before, and there was a relatively simple solution that helped you, that had a relatively low risk of harming you. For example, a muscle relaxant is usually safer than something like morphine. I cannot imagine why I would not quickly give that to you. I'm so sorry. I don't know why that happened to you in that way. I think there's also bias about the condition, because I can only imagine that when you say, oh, I have painful period cramps, I can only imagine the people that roll their eyes, even some of whom have periods themselves. But I really think that this is just a lack of understanding and listening. It's so interesting to me how one of the main goals is to move people through the ER.
Yeah.
And how you presented such a simple solution that it would be idiotic of me not to try that if my goal is to get you to the next space, which is either you need to be admitted to the hospital or comfortable at home.
Right.
And so there really is no easy answer as to why, other than the fact that you weren't listened to, your concerns weren't validated.
Yeah.
And unfortunately, if you did get upset and angry, then that would become a new problem.
Oh, right.
And so I have no answer for that because that's just not how I practice.
Good.
But hopefully talks like this help people understand that's not how you should practice. Sometimes it can be so simple.
I'm not going to lie. It was very validating to have Dr. Darien tell me that there's no good explanation for why I got bad treatment at that ER. That's a 6-year-old question I can just put to rest now. Okay, hi. I know that these episodes are dense. I know that they're packed with information, and between that and talking about medical experiences and periods and stuff we don't usually talk about, it's a lot. So I want to give you a little break, but not for ads. I've been finding some incredible songs about period cramps, usually by independent artists that I hadn't heard of before. So from here on out, every so often, when I feel like we might need a break, I'm gonna play you a piece of a song about period cramps that I absolutely love. This one is from a band called the Handjob Academy, and it's called Shark Week. I'm obsessed. It's in my shower playlist.
What you gonna say, huh? Strap on your red wings, it's time to make this bird sing. My bed looks like the elevator from The Shining. Contemplate, don't hate, cause I look like Sharon Tate or a piece of rare steak when I masturbate. Bleeding since 11, bitch, I ain't new to this. Feels like a werewolf is living in my uterus. Are you on your periods this morning? Shark Week.
Okay, I feel refreshed and ready to get back to my conversation with Sydney and go over some research. Both of us, from very different people in these situations, encountered some kind of bias, right? Encountered somebody not believing us, somebody questioning if it was really that bad, or just straight up like not getting help because you're not being listened to. So I really wanted to dig into what is that bias? Where does that bias come from? Why would some patients be listened to more than others?
Well, I have an idea. As a Black woman moving through the world, I'm like, oh,
Sure.
well, I think it's probably because of one or two things.
At this point, it's a generally accepted idea that bias affects what kind of treatment people get. And we know there's bad doctors and good doctors, but I still have faith that most people who go into medicine genuinely want to do good and help people. I don't think there's a statistically significant number of people working in medicine thinking women don't deserve to have their pain treated well. So where does it go wrong? Where and how does bias get in the way? To find answers to these questions, I looked at a 2001 article in the Journal of Law, Medicine, and Ethics. The journal is called The Girl Who Cried Pain, A Bias Against Women in the Treatment of Pain. And just a quick note on gendered language here. This is from 2001, and if it were published today, it would probably handle the gendered language differently. As we discuss findings from the paper, I'm going to use the terms they use, men and women, as they do, knowing that gender is a vastly more interesting and complicated identity than simply the equipment that you were born with. This article, The Girl Who Cried Pain, reviewed 127 studies and publications in order to answer questions like, do men and women perceive pain differently? And do differences exist in how men and women's pain is treated in medical settings?
I'm going to say hell yes. And my prediction is that women have a much higher pain threshold.
Yep. Okay, that was my prediction as well. So for the question, do men and women perceive pain differently? The answer is yes. Based on the research they reviewed, men and women do experience and respond to pain differently. And there are a lot of mixed results, we should say, and it states in the paper, there is no cut and dry, clear answer. It really depends on how you're testing, but the results that show differences show them all in the same direction, which typically means there is something there.
Okay.
And this may surprise you, but there does seem to be a general consensus that women tend to have a lower pain threshold, higher pain ratings, and lower pain tolerances than men. Women will describe a certain level of stimulus as painful before men will. So that's a pain threshold when a stimulus goes from just being like a thing you can feel to a thing that you're like, that's painful.
Okay.
Higher pain ratings mean a certain level of stimulus that both men and women say is pain. Women will rate it higher on a scale of 1 to 10 at the same level than men will. And then lower pain tolerance is the point at which you tap out, where you say, no more stimulus. It's too painful for me to keep doing this.
So women have a lower tolerance as well?
In laboratory settings. And that's what I think is so important, is when women are able to say, hey, that's painful and I don't want to do it anymore, then they tap out earlier than men. But that's not how the world works.
See, what I expected you to tell me was that, yeah, maybe lower pain threshold. The tolerance surprises me, but I'm also like, women are better at asserting their needs.
Yes.
And so if you're telling me that you'll stop doing that as soon as I don't like it, yeah, I have nothing to prove to you. I'm going to tell you to stop as soon as it hurts.
Yes, exactly. If you have control over it, if you don't have to deal with it, if you can choose to stop being in pain, yeah, why wouldn't you stop being in pain earlier? So for the second question, do differences exist in how men and women's pain is treated in medical settings? That's a definite yes. There is some wild shit in this part of the article that really shocked me.
Oh, God.
While men and women presented with similar levels of pain, women were less likely to receive analgesia or pain relievers, and women who did receive analgesia waited longer to get it. And this sounds very familiar to me. This sounds like getting anti-nausea medication instead of the muscle relaxant that would help me, or the morphine that would get me out of my pain. My pain was treated with something other than a painkiller, and I had to wait a long time for my pain to eventually be treated. And the craziest part is that this finding is also true for children.
What?
If they got their tonsils out or something, like just normal kind of childhood surgeries. Boys are more often prescribed codeine, which is a painkiller, while girls are more often given acetaminophen, which is an NSAID, also for pain, but it's way milder. It's for pain that is less of a problem. So this suggests that doctors perceive boys to be in more pain than girls.
Oh my God.
Even before puberty, even before we're talking about like women and men, this is boys and girls, children.
That's so crazy that it starts so early when we're just children.
I know. There have also been multiple studies that have found that men are more likely to be prescribed opiates for pain, and women are more likely to be prescribed sedatives and antidepressants for the same complaints.
Oh my God.
These studies are pointing to a meaning that doctors seem to interpret men's pain as being caused by something quote unquote real or physical, and doctors may interpret women's pain as being caused by something psychological like anxiety. So not needing to treat a physical source of the pain.
That's so upsetting.
I'm not saying we should all get opiates all the time. Like opiates are not the solution here, but especially in this article from 2001, it is a decent measure of whose pain is being taken seriously.
Oh, absolutely.
Yeah.
Wow. I honestly thought what you were going to tell me was that when you look at the actual scientific research, we have identical levels of pain. It's just that women put up with a lot more. Like it will take us longer to reach a breaking point. And that is true in the outside world of like, okay, I have to go to this meeting. I'm dying inside. But okay.
Right.
Yep. I just spent hours on the toilet, whatever. Who cares?
But what you said about like, you thought it was going to be scientifically measurably even, the same amount of pain tolerance, but actually women feel more pain with the same amount of stimulus as men have, which means the fact that we're waiting so much longer than men to get treatment means we're in pain even longer than if our pain levels were equal.
Yeah, which is more so what I meant with tolerance. I just meant that we have to endure, so we do. I don't think we should have to.
Yeah, and I think the meaning of all of this really ends up being we deal with what we have to deal with. It's funny that there are so many stereotypes of like men as wimps who can't deal with pain.
Well, unless they're like in prison or in some horrible environment.
Or they're, you know, in the middle of the woods, like 127 hours.
Oof,
There's all of these feats of manliness and dealing with pain.
Mm-hmm.
But I think all that shows us is that humans are incredibly resilient. And if you have to deal with something, you probably can. But why are women having to deal with it?
On such a daily basis.
Knowing how much the odds are stacked against us, knowing how deep this bias goes, I asked Dr. Darien if there were certain phrases or words that we could use when we're having severe dysmenorrhea and we're trying to get through to an ER doctor to make it more likely to get good treatment.
Using your story as an example, I think you've done everything right. You stated that this has happened to you before. You've given a simple solution. I really don't want to change what you are doing because personally, I think that's the appropriate method of communication. And bringing an advocate, unfortunately, is necessary in these situations. Having someone there with you, that's the one advice I can give to everyone. Having someone there with you who's not dealing with pain and can help you think more clearly and objectively is really helpful. And also can provide more history because it can be so difficult when you're in extreme pain to not only be a patient, but also be your own advocate.
All right, crampers, you heard Dr. Darien. The number one thing you can do to get better treatment in medical settings, especially when you're in severe pain, is bring someone with you who can advocate for you. Maybe find another person who experiences severe dysmenorrhea and do the buddy system. You call them for your emergencies, they call you. I asked Dr. Darien what we should do if we ever have a bad experience in an ER like this again.
You know, when these things happen, especially an experience like this, I advise patients it's really important to write letters to the hospital or emails. Describe your experience because many people might think that those emails or letters do not get to us, but we have to answer to them. And as a physician, you have to show your documentation, show your reasoning, and people follow up on it, and it's taken very seriously. So my advice, and this is an emergency physician giving you this advice, complain. I think writing letters and complaining is an effective form of getting a response that is hopefully going to prevent this happening to you again and also happening to other people.
We have a lot of information now about why things have gotten this bad for women seeking medical attention for severe pain. I wanted to ask Dr. Darien's perspective on how things could get better. This is like a big meta question, but what do you think would have to change? And I'm talking specifically women with severe menstrual pain to get better treatment, more information, not have their pain dismissed. What would have to change?
As someone who travels through the healthcare system myself, and I know how difficult it is because even with my privilege of being a physician, I still hit walls and I'm like, why is it so fucking difficult to get care.
Yeah.
We live in a country which is one of the only 11 high-income countries that doesn't provide healthcare to all of its citizens.
Right.
And with that, we're having a healthcare system that is becoming increasingly stressed. And when that happens, it cracks. And when that happens, the most marginalized people fall through those cracks.
Absolutely.
And that includes women, people of color, anyone who is othered in any way, shape, or form. And so I'm often fielding these questions from my friends because they just don't feel heard.
Yeah.
And then I also have some sympathy towards the providers because we're dealing with a system that is putting immense pressure on physicians to turn over, to quickly see patients, and it's taking away the art of medicine that so many people join for. So number one, education needs to change in terms of communication. We talked about this already, but making sure that as providers go through the training system, they are good communicators. And a part of good communication is not just talking, it involves active listening. Then the training needs to be formatted so that we can understand and have more perspectives like this. And then I think that there's a part of this which is policy and politics. And unfortunately, a lot of our politics does not center on what it should, which is preventative care and also access to care in general. And so I think that it is a multifaceted, needed approach. And is it easy? Absolutely not. Is it possible? Yes.
I love that. I've been really angry at that ER doctor for a long time. Honestly, I've been really angry at most of the doctors I've ever seen. Any doctor I've asked for help with my cramps and have hit that dead end. I've been seeing these doctors as the problem. Like if they only cared more or were more curious about my pain or were more willing to look something up before dismissing me, then I wouldn't be in pain. And after talking to Dr. Darien, I do still think there are some doctors out there who are just straight up dicks. But I think most doctors are just doing their best in a system that is not working. So even if you get a doctor who genuinely cares about figuring out what's wrong with you and easing your pain, someone who is willing to put in the work and who is smart and informed and keeps up with the latest in their field, all the things we want doctors to be, they are almost definitely assigned more patients than they can realistically give quality care to. Honestly, after hearing the reality of hospital care from a doctor's point of view, it's kind of a miracle any of us get the care we need at any time. Speaking of which, I have one last question for Sydney. I want to ask, you said that you have not had period pain for quite a while. What was it? How do you not have it?
Well, I did have a bad week a few weeks ago, so I
So
won't say
immediately
it's
reversing.
completely gone. It's not completely gone. It's just, it's not at the same level whatsoever. I eventually got an IUD, the smallest IUD that you can get, the Skyla.
Yeah.
And I had never been on birth control in my life. I really did not want hormones in my body. I didn't think I would respond well to them.
Yeah.
Luckily enough, my body seems to be doing well with it and they are localized.
Good. Okay, I have one last piece of research that I saved for last, and I think you're going to enjoy this.
Oh, goodness.
There was a study that found that, quote, physically unattractive patients were more likely to be perceived as experiencing greater pain than more attractive patients. And that the more attractive patients were more likely to be viewed as being able to cope with their pain.
Wow.
So being hot makes doctors not take your pain seriously because you look so hot. How could you be in pain?
Oh my God. Wait.
And yes, this attractiveness bias is way worse for women than for men.
Well, of course.
So Sydney, that's why we've gotten such bad care. We're just too hot.
No, Kate, that's why I got such good care. Because when I showed up at the ER, I looked like a gremlin.
For our next episode, we're going deep into the data on period pain to try to answer the question, how many people experience severe period pain? Like truly, how many of us are there? Join us next week to find out. Cramped is hosted and created by me, Kate Helen Downey. Kelsey DeLonzo is our editorial producer. Sound design and mixing is by Kelly Kramerick at Maven Post Media. Our associate producer is Caitlin Sabater. Cramped's incredible theme song is written and performed by Faraday. Our podcast art was created by Nicholas Shepard. This podcast is supported by the Simons Foundation's Science, Society, and Culture Initiative. Fiscal sponsorship for Cramped is provided by the Arkansas Podcast Collaborative. If you'd like to hear more from Dr. Darien, you can follow him on Instagram or TikTok at dr.darien. He has a new series coming out this spring about abortion rights called State by State. And you can follow Sydney Battle on Instagram or TikTok at Syd Battle, SYDBATTLE. Special thanks to Mia Lobel, Yvette Modenow, and Matthew Starr.
What's happening to your body? We don't know, because we've never really studied the female body.